So, good afternoon, everybody. So let's start, perhaps. We are talking about emergency use authorization. For me, as for some of you, it was a new thing. This is my disclosures. So you know that in the לא שומעים? ככה יותר טוב? שומעים עכשיו? So following emergency use authorization of the Pfizer-BioNTech BNT162b2 vaccine by the FDA, authorization was granted for use in Israel, and on December 20, a national vaccination campaign was initiated. So I maybe skip what we are talking about, the vaccine. And about 3 weeks after the initiation, on January 10th, the first patient ever with post-vaccination myocarditis was hospitalized at our department. And I reported this to the MOH and the WHO. From the WHO, I didn't receive an answer till today. But the MOH was quite efficient and rapid and wanted the data and even established a committee to follow up this phenomena. And we started with a passive surveillance. I went to the hospital. I said, who is here with myocarditis in the last 2 weeks? And other hospitals, etc. But after we realized that there are quite a number, and it is something we should follow up, I think it was Sharon's idea to do an active surveillance. And this is something very, very important that I think I didn't realize at that time how important it is. And we did, actually, we asked all the hospitals in Israel, 26 or 28 hospitals, to report any case of myocarditis in Israel in relation or not to vaccination. And this was published actually in 3 papers that we did about the phenomena of myocarditis after the mRNA vaccine. In this case, it was Pfizer. This was found also, as you may know, in Moderna. We also looked at it in adolescents and also in the third booster. And actually, we did what is called active surveillance, where we reviewed all this data and tried to correlate it to vaccinations. And we did some descriptive frequencies, percents, means, incidence, etc., age, female, male. And we actually analyzed it in 3 ways, both rate ratio between vaccinated and unvaccinated individuals, overall risk difference between the first and second, and observed to expected ratio, and expected based on the occurrence in the years before the pandemic. So this is what we saw, actually, and you don't have to be an epidemiologist to see that something is happening here. And the occurrence of myocarditis is accumulating as the vaccination progresses, and actually this was further analyzed to show that you see that this is divided by gender, and you could see that males are predominant here, and also ages, and you could see that the young ages were predominantly frequent, and also that the second vaccine was actually the vaccine that was mostly associated with myocarditis. So this is more or less the results. And in the youngest population, which was 16 to 19 years, it was estimated as about 1 to 6,000 in this active surveillance we did. In the younger population, 12 to 15, it was a little bit reduced to my I was very happy with this result because it actually imitated the natural myocarditis that occurs in the population usually in almost any myocarditis, which is peak incidence at the puberty in the ages between maybe 13, 14 to 19. And children that are not mature do not experience myocarditis. And as you become older and older, the rate is declining. So there were many others that reported similar phenomena. We don't have to go into that because of this is not the main subject here. But if we put our results and we look at the ages, the booster, the first, second, third, and we could see that there is some kind of increase towards this, what I said, the 16, 19 years, and a decline later. I can add here that children did not experience myocarditis like the very young children. There were some differences with the numbers in the United States, but I have to remind you that this is actually an active surveillance, and in the United States still today the collection of data is passive with all the facilities and whatever. If a patient do not complain or a doctor do not report, you won't get it. And here we did something very, very exceptional in that regard, that we took all the cases of myocarditis and analyzed them. Are they related or not to the vaccination? What is the mechanism? Again, for the sake of time, we won't go into it, but just to say that the mRNA vaccine is both doing translation for the protein, but also the RNA by itself is a self-adjuvant and interact with the toll-like receptor 3, 7, and 8, and maybe in predisposed patients it develop myocarditis, and I think we have very nice data about predisposition for this problem, which hopefully will be published soon. So this raises the question of adverse effects in vaccination, which is some kind of bioethical question related to this meeting. And in AEs, in adverse effects, we always have to look at different aspects. Are these AEs mild or severe? We all heard about a little bit irritation in the place of the injection and things like that. But are they fatal? Like we had one patient that died, at least corresponded to vaccination, but he died, she died actually. Are AEs very likely, probably, possibly, unlikely, unrelated, unclassifiable? Are AEs collected passively or actively? Most of the world collect them passively. Are AEs idiosyncratic, like anaphylaxis, or general? And as I mentioned before, even the word idiosyncratic is somehow misleading, because there are some people that have predisposition to this adverse effect. How do you calculate the risk-benefit? And how could AEs change vaccination policy, public behavior? So risk-benefit, I learned from my friends that were in the group that we worked, and some of them were able to somehow to get to a calculation that take into account both hospitalization, severe cases, death, school absenteeism, work absent, transmission to other age group, etc. And at the time of alpha, maybe also delta, they concluded that it might be risk-benefit of 5 times to give vaccination than not to give it, at least in the age 16 to 19. In the total population, it's much more. However, the question remains, is it the same in Omicron, which is a little bit less severe disease. So now I want to switch to EUA, the Emergency Use Authorization. And before the COVID-19, most of us weren't familiar with this term, I guess, apart from maybe the professionals here. But we never heard about it so much. And it is a tool of for the FDA to expedite the availability of medical products, including drugs and vaccines, during a public health emergency. And this turned to be very important in my eyes, because if you look back, one of the first events with an impact on that was the thalidomide story, although not related directly to EUA. But you know that thalidomide that was actually forbidden in the States by the FDA and caused in other countries that allowed its use these severe birth defects, it actually taught us the importance of FDA regulation, the importance of agency extensive and thorough formal approval process. And I think this has an impact on many health providers and health workers. Another historical event is the Spanish flu. Sorry, not the Spanish flu, the vaccination to influenza A, that in '76 there was some kind of possible pandemia. And there were, at that time, the President Gerald Ford pushed for a first ever national vaccination program. And the pandemia did not realize, as I read. On the other hand, there were some cases of Guillain-Barré syndrome. And there, I think there was some kind of loss of trust of the public about that. This is in contrast to the impact of the thalidomide. And then there was the AIDS that we heard yesterday about this parallel track that I won't go into that. And so how long have the EUA been around? The FDA established it in 2004 in response to threats of bioterrorist attack, including anthrax, and later H1N1, Ebola, avian flu, Middle Eastern respiratory syndrome, and other major public health threats. But I think it never really got into a test till the pandemia, the current pandemia. And we have to mention that here that EUA can be revised or revoked by the FDA at any point. And we all know that hydroxychloroquine was approved at first, both because of some data that was possible, and also maybe there was some kind of a push from the Trump administration. I don't know. Maybe our friends from the US can clarify that. But, and I used hydroxychloroquine at the beginning, but then when we realized that it's not so helpful, we stopped it. You could see here that actually if you look at, if you look at the percentage of treated patients in the first wave, you could see that hydroxychloroquine, 16% got it. However, in the second wave, it was really few percent. On the other hand, steroids that were not used so much in the first wave rose dramatically after we realized from studies from England that steroids could help the lung involvement. So, so far there were in 2 vaccines, the Pfizer Biotech for ages 16 and up, and Moderna, and one Gilead remdesivir have gone on received a full FDA approval. And on the other hand, a week ago we heard about a request for the authorization for vaccination for the children with the new vaccine that was applied by the companies, the Pfizer BioNTech. Okay, so how does the EUA process differ from the full FDA approval? So we won't go into it deeply, but mainly it is shorter supervision after the drug. It is only 2 months, whereas in with the full approval, you ask for 6 months. And actually, just if we look at myocarditis, typically it occurred within 1 month after the, so it felt quite okay with this. And there are some differences in the DSMB work and other committees. I don't think we should go into that. But what is important is that there is a continued monitoring. So manufacturers are expected to have a plan for active follow-up for safety, including, of course, death, hospitalization, and other serious adverse effects among these patients that receive it. And I think there is also us, the doctors and patients that are reporting, and you know very well that this was quite interesting. By the way, I saw a slide, the number of reports of adverse effects after vaccination in different countries. And it is a cultural thing. You could see that where were the most reports? You know which countries were there? USA. Huh? USA. USA, no. It was Japan and Italy. And you see very different mentality, and yet you got, you have some cultural effects there, of course, and we have to monitor everything as we could do. So this is very interesting. How long a full FDA approval is taking compared with the EUA? And somebody mentioned here, I think, that it is about 8 years. And you could see here that according to one of the studies, 21 vaccines that were approved took in average about 8 years. And COVID-19 was the first to receive the EUA, was under clinical development for 6 months before it submitted to its EUA, and EUA was granted in less than a month. Full approval was issued 8 months later. I think it was August. This is amazing year. You could see what happened in 1 year in this, the milestones. Since the SARS was sequenced in China, actually, at January 10th, 2020. And you see step by step, 1 year passed, and you have already healthcare providers that are vaccinated. I think it's amazing achievement of, I don't want to say Pfizer and BioNTech, but I think of science somehow. And the EUA was a tool for emergency status of the world somehow. The question is, should we do all approvals in this way, perhaps? So those who are against, of course, says, no, we compare here apples to oranges. And we should not do that. I'm sure that we could do better than 8 years, but it involves a lot of money and preparation and regulation. So we have to accept that we have 2 modalities, and they are very important, perhaps. And if you want to understand why, for instance, the first study did not see any myocarditis event, you could see that actually there were only 9,000 males in this, and I would say maybe 3,400, 4,000, I didn't find the exact number, were at the ages of 16 to 30, where you get only 1,000 to 6,000 myocarditis. So this is not enough. This study that had 20,000 patients was not enough to discover it, and we have to understand that. And this is not the only problem, because you could see here that minorities are not presented. And there might be there might be some problems that are specific to minorities, to some ethnicities, etc. On the other hand, the Brown School of Public Health calculated that in 1 year, about 3,000 deaths could have been prevented if people would take the 300,000 if would take their vaccination. And this is a paper from May from Lancet that showed that vaccination actually prevented 14 million deaths in the worldwide. So I think that if I can conclude, that EAU used during the pandemic was probably appropriate and saved millions of lives. Myocarditis that was missed in the fundamental studies would have not been identified, most probably, using a full FDA approval. However, we should not lose public trust by ignoring possible adverse effects, and risk-benefit review should include a spectrum of ages, gender, ethnicity, variant, and more. And I will stop here and thank many collaborators in the Ministry of Health, in my lab, in the hospitals, and thank you very much.